Hello, everyone. I am Madeline Milka, President and CEO of APAICS, the Asian Pacific American Institute for Congressional Studies. I am thrilled to welcome you to an APAICS congressional briefing in honor of National Minority Health Month. We are grateful to have you all here today to discuss the pressing issue of heart health equity within the Asian American, Native Hawaiian, and Pacific Islander community. I would also like to extend my sincere thanks to our briefing partner, Amgen, and all of our special guest speakers and panelists. Before we dive into our discussion today, I wanted to share a few facts about the state of cardiovascular disease in America. Cardiovascular disease is a leading public health crisis in the United States and has been for the last 50 years. On average, every 40 seconds, someone has a heart attack or stroke. Heart disease disproportionately affects certain AA and NHPI populations. This is why we are continually trying to raise awareness of heart health. It's important to recognize that cardiovascular disease risk factors are not distributed uniformly across all AA and NHPI groups. For example, people from South Asia, including India, Pakistan, Bangladesh, Nepal, Bhutan, Maldives, and Sri Lanka, are at heightened risk for cardiovascular disease as compared to other ethnic groups. More than 1/3 of South Asian men and 17% of South Asian women have metabolic syndrome, including abnormal cholesterol levels that increase the risk of heart disease, stroke, and diabetes. Further, higher Lp(a) concentrations, which is one type of LDL or low-density lipoprotein, and another risk factor for heart attack or stroke, carries an especially high population burden in South Asians. Cardiovascular disease remains a leading global public health crisis, and we continue to see persistent barriers that prevent AA and NHPIs from getting the care they need. This includes access to screening services for LDL, or bad cholesterol, one of the most easily modifiable cardiovascular risk factors. It is now my honor to introduce CAPAC Executive Member, Congressman Ami Bera. Congressman Bera has represented Sacramento County since 2013 and is the longest-serving Indian American in Congress. He currently represents California's 13th Congressional District. He serves on the House Foreign Affairs Committee and the House Permanent Select Committee on Intelligence. Please welcome Congressman Bera.
Hi, I'm Congressman Ami Bera, Dr. Ami Bera, and want to thank APAICS for bringing awareness and raising awareness on heart health in Asian Americans in the AAPI community. We all know sometimes Asian Americans, the AAPI community, aren't included in clinical trials, but we know the heart disease rates and cardiovascular disease rates are increasing in our community. So thank you to APAICS. Thank you for raising awareness. Let's make sure we focus research on this niche in the Asian American, Pacific Islander, and Native Hawaiian communities, and make sure we keep our hearts healthy. Be well.
It is my honor to now introduce CAPAC Associate Member Congresswoman Amelia Sykes. Congresswoman Sykes is currently serving her first term representing Ohio's 13th Congressional District and is the first Black person to represent her district. She currently serves on the Committee on Transportation and Infrastructure and the Committee on Science, Space, and Technology. Please welcome Congresswoman Sykes.
Hi, I'm Congresswoman Amelia Sykes, proudly representing Ohio's 13th Congressional District. I want to thank the Asian Pacific American Institute for Congressional Studies for organizing today's panel on advancing cardiovascular health equity this National Minority Health Month. I'd also like to recognize today's esteemed panelists for their contributions and expertise. Thank you for shedding light on the importance of heart health equity. Cardiovascular disease is the #1 cause of death in the United States. While many heart attacks, strokes, and deaths caused by cardiovascular disease are preventable, the widespread lack of awareness and subsequent lack of screening, diagnosis, and treatment only exacerbate the disproportionate impact this disease has on women, and particularly women of color. That's why last year I led the bipartisan Women's Caucus letter to the U.S. Health and Human Services Secretary Javier Becerra, calling for the department to prioritize women's cardiovascular health. All women, no matter who they are, where they live, deserve quality, affordable cardiovascular care with a focus on prevention. This also includes access to innovative treatments when needed. Special attention should and must be focused on the disparities that exist among racial and ethnic groups, including the Asian American, Native Hawaiian, and Pacific Islander community. When awareness and prevention are not prioritized in these communities, it can be harder to identify and treat, which further cements the systemic racial disparities of the disease. Prioritizing awareness and prevention will help save lives in the Asian American, Native Hawaiian, and Pacific Islander communities across the United States, including in my district in Ohio. The work that the Asian Pacific American Institute for Congressional Studies is doing to spread awareness on issues like cardiovascular disease is truly commendable, and I cannot thank you enough for your advocacy. In Congress, I'll keep working alongside groups like the Asian Pacific American Institute for Congressional Studies to ensure everyone in my district and the nation can lead long, healthy, and happy lives free from cardiovascular disease. Thank you very much.
Next, I would like to introduce Nevada Assemblyman Yui Win, who was first elected in November 2022 and is currently serving his first term representing Nevada's 8th Assembly District. Assemblymember Win serves on the Government Affairs Committee, the Health and Human Services Committee, and the Revenue Committee. Let's give a warm welcome to Assemblymember Win.
Greetings from Las Vegas, Nevada, the heartbeat of the Silver State. I am Assemblyman Yui Win, representing the largest Asian American, Native Hawaiian, and Pacific Islander population in the state of Nevada. And it's an honor for me to address you today as we discuss breaking down barriers to foster equity in cardiovascular health among the Asian American, Native Hawaiian, Pacific Islander communities. Before starting my remarks, I would like to give greetings to the amazing leadership and staff at the Asian Pacific American Institute for Congressional Studies, especially the President and CEO, Ms. Madeline Milke. As we gather during National Minority Health Month, under the guidance of APAICS, I'm reminded of the journey that brought us here. Growing up in a community where health disparities were palpable, as an immigrant, I witnessed firsthand the struggles faced by many in accessing quality healthcare and managing chronic conditions like heart disease. Heart disease doesn't discriminate based on race or ethnicity, but the reality is that its impact is not evenly felt across all communities. Native Hawaiians and Pacific Islanders are diagnosed with coronary heart disease at a rate 10% higher than non-Hispanic Caucasians. South Asians face a 40% higher chance of mortality from heart attacks than the average population. Heart disease is the leading cause of death among Filipinos, representing 32% of all Filipino deaths. For too long, the Asian American, Native Hawaiian, Pacific Islander population have been facing barriers that hinder their access to care and exacerbate our health outcome. But beyond the statistic and the data lies a deeper truth. A truth that resonates with a lot of us personally. It's the experiences of family, friends, and neighbor who face systematic barriers in accessing preventive care and life-saving treatments. Today, as we convene to address these challenges, let us not forget the human element. The faces behind the statistics, the voices longing to be heard, and the lives that hang in the balance. One of the most significant barriers we must confront is the stigma surrounding seeking help. As an immigrant, I have witnessed firsthand the reluctance within our community to acknowledge health issues, let alone seek professional assistance. It's a stigma deeply rooted in cultural beliefs and fear of judgment. A stigma that we must work together tirelessly to dismantle. In addressing the multifaceted nature of this issue, we must also prioritize concrete actions to affect change. As the co-chair of the National Asian Pacific American Council of State Legislators, Health, Human Services, and Housing Committee, an organization with over 200 plus state legislators across the United States, I am proud to say that we are hard at work in prioritizing healthcare for our diverse communities, such as language access services to ensure that healthcare facilities offer interpreters and translated materials to facilitate communications and improve health literacy among AA and HPI individuals. Additionally, allocating resources for cultural competency training for healthcare providers is crucial. Such training enhances providers' understanding of the unique needs, beliefs, and practices of the AA and HPI communities, ultimately leading to better patient care. Furthermore, advocating for data disaggregation is imperative. By collecting specific data on each subgroup within the AA and HPI community, policymakers can identify disparities and tailor interventions accordingly. Amidst the challenges, there's hope, a driving force inspiring us forward. It's the collective determination of individuals like yourselves committed to enacting change and advocating for equity. Communities show resilience as we unite to dismantle barriers, paving the way for a healthier, brighter future. As we embark on this journey together, let's do so with compassion, empathy, and a steadfast dedication to supporting those most in need. Let's amplify the voices of those often overlooked and work together to create a future where cardiovascular health disparities are a thing of the past. Thank you for your unwavering commitment to this cause, and I'm deeply grateful for the opportunity to stand alongside you as we discuss health equity. Xin cảm ơn quý vị. Thank you very much.
Our briefing today is entitled Breaking Barriers, Advancing Cardiovascular Health Equity in AA and NHPI Communities. Our panel of experts will explore the factors contributing to the disproportionate burden of heart disease among AA and NHPI populations, including genetic predispositions, cultural influences, and healthcare disparities. They will examine the current barriers faced by patients and providers in managing cardiovascular health and discuss actionable policy solutions to close the gap in cardiovascular disease care for members of the AA and NHPI community. Let's give a warm welcome to our panel. And now I'd like to introduce our distinguished panelists. Dr. Dharmesh Patel is the president of Partnership to Advance Cardiovascular Health, a nonprofit coalition for cardiovascular health. He works at the Stern Cardiovascular Foundation and Baptist DeSoto Hospital and is a board member of the National Lipid Association and the American Society of Preventive Cardiology. He is also a clinical professor of cardiology at the Baptist University College of Osteopathic Medicine and a former leader of the American Heart Association in Memphis. And he has been named Best Cardiologist in DeSoto County 4 times. Maya Sharaya is the Strategic Planning and Operations Director for U.S. Value and Access at Amgen, where she is responsible for overseeing a key strategic portfolio related to the rapidly evolving U.S. healthcare system. And last but not least, Adam Carmelito is the Director of Policy and Advocacy at the Association of Asian Pacific Community Health Organizations, an association that works to improve the health and access of AA and NHPI and other communities through advocacy, collaboration, and leadership. Now let's get to our panel discussion. Dr. Patel, I'm going to start with you. What is cardiovascular disease and how does LDL cholesterol or bad cholesterol relate to it?
Hi, Madeline, and thank you for that question. What is cardiovascular disease? Certainly is a very important topic. The number one killer in the United States, cardiovascular disease itself, is really synonymous to the fact of cardiac disease. And when I say that, that could be things like a heart attack. But when you say vascular, that also means other vessels or vascular structures in the body, such as a blockage in the brain or a blockage in the leg causing a peripheral vascular disease or amputation. So cardiovascular disease itself is not just cardiac, it also encompasses strokes, heart attacks, amputations, peripheral vascular disease, and other things like this. And this is why it's the number one killer in the United States today, killing about 1 in 3 females.
That is a sounding statistic for you to share. So Meha, how prevalent is cardiovascular disease in the AA and NHPI community in the United States?
Yeah, thanks, Madeline. So when you think about the cardiovascular disease burden in the United States, another stat to add to what Dr. Patel just mentioned is approximately once every 40 seconds, someone suffers a heart attack. Now, within specifically the Asian American community, cardiovascular health is rising at rates much more rapidly than for white adults. And specifically, I'd love to talk a little bit about the South Asian subgroup within the Asian American community. A recent study, the Annals of Internal Medicine, studied first-generation immigrants in this country, South Asians. 44% of the participants were found to have 2 or more metabolic abnormalities, such as high triglycerides, hypertension, as compared to 21% of whites. Now, another interesting finding from this study was the study also looked at the cultural connection that these immigrants have to their home country. Some of us here might be first-gen immigrants, children of immigrants. And what was very interesting about this study is the highest cardiovascular risk was actually on the sides of the spectrum of where the participants had very close connection to the home country, maybe from religious custom perspective or from their dietary custom. And then at the same time, those that very vigorously adopted a Western lifestyle. Again, those are the highest cardiovascular risk. The lower risk was somewhere in the middle, what the study refers to as bicultural, which is maybe some of us can relate to that. Bicultural, I like to think of as the best of both worlds, adopting healthy habits, both from the South Asian lifestyle as well as the Western one.
Well, thank you for sharing that information. Adam, why are we seeing such striking cardiovascular disease numbers in some AA and HPI patients?
Thanks, Madeline. And that is such a good question, but it's also a very difficult question to answer because there really isn't one answer. When we're talking about the collective Asian American, Native Hawaiian, and Pacific Islander community, we're really talking about a diverse population that's made up of more than 50 ethnicities, speaking more than 100 different languages. And each community has their own set of cultural heritages, cultural practices, ancestries, how they came to the United States, and their experiences with the U.S. healthcare system. Our communities are not a monolith. It's something that I know we've heard many times before, but it's especially important when we're talking about a healthcare setting. And it's important to recognize the differences in genetic predispositions to certain diseases, cultural differences, socioeconomic differences, lifestyle, diet, and other risk factors within subgroups of the Asian American, Native Hawaiian, and Pacific Islander community. Those all contribute to the high prevalence of cardiovascular disease among our people. There are also significant barriers for many in our community to access the healthcare system in the United States, especially among those who may be new immigrants to the United States, those who are low income, and those who may have limited English proficiency. The top 2 barriers that we see in an individual's decision to seek medical care are insurance status and a language barrier. And this poses a significant challenge to our communities, given that about 60% of Asians and a quarter of Pacific Islanders in the United States are foreign-born. Federal law largely prohibits immigrants from accessing most health and social benefit programs, such as Medicaid and food assistance, for the first 5 years that they're in the U.S. Asian and Pacific Islander languages are often not prioritized when materials are translated. Call lines and help centers are often confusing to navigate or have extremely long wait times. And the healthcare workforce shortage is exacerbated for our communities when we're unable to hire and maintain multilingual staff and multilingual providers and non-clinical staff. All of this is just speaking in the aggregate and not even getting into how deep the problem is for certain subpopulations, as Mia was saying, within our communities. Data sets, especially at the federal level, often only report aggregated information into a broad API category, or if we're lucky, into a separate Asian group and a separate Native Hawaiian and Pacific Islander group. But this makes the specific challenges that certain subpopulations within our communities, it makes them invisible, and it masks what needs to be done to address their specific disparities. Without better data, we will continue to see high rates of negative health outcomes for AA and NHPI communities. And many of our community partners, and APCHO have been working hard to get better data for our communities. We have seen some progress. Most recently, the Biden administration last month released new guidance through the Office of Management and Budget to require all federal agencies, not just in healthcare programs, but across government, to collect and report granular, disaggregated data, not just on AA and NHPI communities, but in all race ethnicities throughout the country. We hope this will lead to better understanding of diseases like cardiovascular disease within specific populations, and ultimately to better health outcomes for all communities, and most especially within our AN and HPI community. So a hard question to answer because of the diversity that we have, but it's really important that we focus on the needs of specific populations within the AN and HPI communities specifically.
So many different factors to consider. I know with heart health problems, it's impacted many of our families, including mine. My mom actually suffered a stroke little more than 8 months ago. So in the sense of trying to better understand your personal experience with heart health, how has this led you to the work that you do? So I'll start with Dr. Patel.
Certainly, this story or narrative is very close to the heart. My story is the fact that my best friend basically died at the age of 42 from a sudden myocardial infarction. He was a pulmonologist. He had moved from London to America. And, I can tell you after seeing about 20,000 patients in my career, heart disease does not segregate or discriminate race, color, socioeconomic status, how you look, what you like to do. I mean, 40% of people that have a cardiovascular event feel great the day before they die. 40% of people that actually have a heart attack don't make it to the hospital. So this was a very big loss for me, and it just showed me that as a physician, I do know that cardiovascular disease is preventable. It's not like a cancer. And it really set me back. It set me back in what I do and what I do on a day-to-day basis. And so with that in mind, I also have the positive gratitude of being able to treat patients and hopefully prevent those kind of fatal tragedies from happening. So as a physician, I saw patients and also saw the anguish of patients not being able to get the therapy that I had actually prescribed for them, or not being able to get therapy that I thought was right. And that's why I took a passionate role in therapies such as in medicines called PCSK9s, which actually help lower the cholesterol about 63%. I was not able to get, ironically, the most highest risk patients in the United States in Tennessee and Mississippi, the therapy they needed. So that's when I was approached about the fact that if I was interested in doing advocacy work for patients, for healthcare professionals, because at the end of the day, when it's the doctor and the patient in the room, unfortunately, it's not the doctor and the patient in the room anymore. It's the doctor in the room, it's the patient in the room, and also the health insurance company. So that's what led me to healthcare policy advocacy, and I feel strongly about it.
Well, thank you for sharing, Dr. Patel. How has this experience as a physician shaped your role as the president of the partnership?
I think once you get involved and you're passionate about something, you really want to see change. And I'm also very proud to say that the Partnership to Advance Cardiovascular Health has really been a supporter of patients, healthcare professionals, and overall the health of this society. We've shown clearly that certain subsets, certain cultures, certain populations, such as AAP-ACS, there are certain barriers out there. And I think by highlighting these issues, these obstacles of healthcare, we've been able to truly make a difference. For example, improving access of care to ethnicities in, for example, Mississippi has been one of my biggest challenges and aims, and we have really tried to narrow that gap, and we'll discuss that later in this discussion.
Thank you so much again for sharing, Dr. Patel. Meha, do you also have an experience that you would like to share?
Yeah, thank you. Thank you both to you, Madeline, and to Dr. Patel for sharing your stories, and condolences for your loss, Dr. Patel. In my family, I suffered a near fatal, but fortunately, my father is doing well today with regards to his heart disease. And I think a couple of words that I've heard already from us is, Adam, you mentioned the word invisible. Right? Invisible to help treat what's preventable. So sometimes it feels, speaking as a member of the South Asian community, while many of us are fortunate to be, come from educated families, perhaps, or our parents worked hard to come to this country. My dad, for example, is a physics professor in rural Michigan. We cannot assume that there is awareness on heart health and how to take care of oneself. My parents have been in a very rural area near Lake Superior for nearly 40 years now, where the best health care is 7 hours away in Rochester, Minnesota, at the Mayo Clinic. So what this means was my dad did not take the steps over the course of the years to focus on what's preventable. Finally, there's the summer of 2021, he felt, okay, a friend nudged him to go get a full body scan at the Mayo. He drove 7 hours. Within minutes, they found he had 98% arterial blockage, which meant that he was rushed into surgery a couple of days later. So what can we learn from this story, right? We cannot assume the information that patients have. We cannot treat Asian Americans as a monolith with level of information. And at the same time, we must educate on specific approaches, such as perhaps if my dad knew about cholesterol screenings and go get your cholesterol checked, the outcome could have been a little bit different. Thank you.
Well, thank you for sharing. Adam?
Yeah, thanks, Madeline. I think similarly, like this is an extremely personal issue because cardiovascular disease touches so many of the lives within the Asian American, Native Hawaiian, and Pacific Islander communities. When I was in 7th grade, my dad had to have open heart surgery with the triple bypass, where three of his four main arteries were 90% blocked. And when he went to see his cardiologist, the cardiologist remarked that he was so fortunate that he came in when he did because if he had suffered a heart attack, it really would have been fatal. And so within 48 hours, they wheeled him into the operating room and his surgery was successful. And our family made all of the recommended changes. We largely eliminated red meat and fried foods from our diet, which is extremely difficult in Guam, where we love to barbecue and gather around a table almost every weekend. We significantly reduced our salt intake. He started to exercise almost every day, and he was able to reduce some of the stress of his job. Fast forward 4 years later, between my sophomore and junior years of high school, he went in for a checkup, and his cardiologist told him that all four of his main arteries were blocked and he needed a quadruple bypass. And so again, he went into the operating room, the surgery was successful, and we made even more changes to our family lifestyle. Fast forward another 3 or 4 years when I was a sophomore in college. My mom who is a nurse, and was working at one of the hospitals in Guam at the time, had a very significant heart attack when she was at work, and she was admitted to the ICU for almost a week while they tried to stabilize her. Our family has been fortunate that both made full recoveries and are living extremely healthy lives today. But even with all of the changes that we made, the risk factors that our family has, the genetic predispositions, cannot be overlooked. But oftentimes, because of the lack of information, the lack of granulated, disaggregated data for subpopulations within the Asian American, Native Hawaiian, and Pacific Islander communities, those predispositions and those risk factors are not really understood, or they're not communicated to the populations that need them most. And that is very true, especially within the Native Hawaiian and Pacific Islander communities, where oftentimes our data just does not exist in data sets. And, me being Native Chamorro, one of the subpopulations within the NHPI umbrella, while we are a subpopulation within the OMB standards, oftentimes we are just an asterisk saying that our data is not statistically sound in order to be reported. So I think the lack of data is extremely problematic, as well as a lot of the other factors that I mentioned earlier. But I'm really hoping that we can get better understanding of how cardiovascular disease and other diseases affect specific populations within our communities, and that really starts with being able to collect and report granulated data. And we're starting to see improvements. I'm hoping that they continue and that more research is provided to our communities.
Meha, what barriers do physicians and AA and NHPI patients face when trying to treat cardiovascular disease and elevated LDL cholesterol?
Yeah, thank you, Madeline. We heard a little bit from Adam right now on barriers, maybe when it comes to cultural, linguistic, education, and so forth. There's a couple of other key barriers that are actually, frankly, created by health insurance companies and pharmacy benefit managers. These two barriers are step therapy protocols as well as prior authorizations. So what does this mean? What is a step therapy? A step therapy protocol it means that when a physician prescribes a medicine to a patient, sometimes a patient must go through other medicines before they can receive the advanced medication, which clearly is further propagating the cardiovascular burden if patients cannot receive the medicine and receive the quality of care when they need it. The second piece I mentioned, prior authorizations. Prior authorizations means means a patient must get approval from their health plan in order to access their medication. This is very onerous. Lengthy paperwork is required by physicians' office staff to make this happen. And worst of all, it takes so long and there's delays that patients might not even get approval. They may get rejected from being able to take the drug that they're prescribed to take care of their health. All this builds up ultimately to sometimes patients and physicians simply giving up.
I do want to piggyback from what Meha said. Being in the trenches on a day-to-day basis, we know that step therapy and prior authorization, to me, are personally just tactics by insurance companies and health benefit managers to really delay therapy and really just for purely financial gain. For example, step therapy. As a clinician, I generally know what therapies work most effectively with the least number of steps. But here I am telling patients to do things which I know are not going to work just to appease an insurance company and not my patient. And then we talk about prior authorization. There was a recent JAMA article showing that my nurses spend an extra 7 hours per week on just filling out prior authorizations. I'm meant to be treating patients, not filling out paperwork. There's statistics like 24% of patients due to prior authorizations leading to hospitalizations. Up to 90% of physicians abandon the therapy because of the erroneous tactics of prior authorization. And remember, whilst we are doing these very elongated, archaic methods, these patients who are extremely high risk do not get their therapy. The patients at the highest risk do not get their therapies and ultimately have further recurrent events. So it's been very well validated that both step therapy and prior authorizations are really not in the best interests of patients. And I also do want to say one thing that we mentioned before, both Adam and May had discussed the fact that, high risk populations, we don't talk about Asian Americans or patients in this society very well because they're not very well studied. But I do remember in 2018, for the first time, the ACC guidelines did clearly say that South Asians or the ethnicity of being South Asian was a, quote, cardiac risk factor. So it's the first time that, the American guidelines appreciated that the Asian American subset population is the highest risk ethnicity for cardiovascular events.
Well, since I still have you, Dr. Patel, tell us more about what information patients should know about LDL-C testing and treatment options.
LDL is what I call the lousy cholesterol, the bad cholesterol, and it's done simply by a lipid panel or a screen, which is a blood test. It's a very affordable test, and the LDL gives us the number of bad particles that are in the bloodstream. Quite simply, in simple terms, when someone's had a cardiovascular event, a high-risk patient should have an LDL less than 55. If someone's diabetic, generally speaking, their LDL needs to be less than 100. We also now have very useful other tools that can help us further define patients who are at risk. There's something now called a calcium score, a simple $99 test which tells you if there's any plaque burden in the coronary vessels, because I do want to mention that LDL or cholesterol is a very, very important risk factor. It's probably one of the most important predictive risk factors in patients who've had a heart attack, because unfortunately, 1 in 5 of those patients who had a heart attack will go on to have another event. So the cholesterol is extremely important. I'm horrified to say there's data show that up to 50% of patients who've had a heart attack do not get their cholesterol checked in the next forthcoming year. To me, that's unbelievable information, but it just tells us the big education gap that our patient population has.
So Adam, how can community organizations collaborate to increase awareness of cardiovascular disease screenings and management of the disease? particularly among underserved populations who carry a disproportionate risk for developing heart attacks and strokes. And can you share some of the work your respective organizations are undertaking in this space? So I'll start with Adam first, then go to Dr. Patel and Maya.
Yeah, thanks, Madeline. I think there needs to be better prioritization and awareness of the importance of culturally and linguistically responsive care. We know that when patients are able to get care in their language and in a way that is culturally aligned with their with their lived experiences, they're more likely to seek healthcare. They're more likely to stay on regimented healthcare, and they're more likely to continue treatments once they have been given that. And I think that is something that has not been prioritized within our healthcare system. I think oftentimes we think of these one size fits all treatment options, but that really does not recognize the lived experiences of patients, and move them in a way that they are most likely to continue the treatment options, and awareness of various issues affecting them. Our work with APCHO, APCHO is a association that represents primarily federally qualified health centers that really do have language and culture at the center of the work that they do. All of our community health centers provide culturally and linguistically aligned care. Our members provide care in anywhere from 14 to 79 different languages, because we know that when you meet patients where they are, they're able to get better healthcare and have better healthcare outcomes. One thing that I am really excited about is that in the next month or so, the Congressional Asian Pacific American Caucus, in conjunction with the Congressional Black Caucus and the Congressional Hispanic Caucus, is going to be introducing the Health Equity and Accountability Act. This is comprehensive legislation that seeks to improve health equity and health outcomes for underserved communities, particularly communities of color. And we are really hoping that Congress will use this as a blueprint on how to address health disparities for our communities. One really important title within HIA specifically addresses high impact minority diseases, including cardiovascular disease, and how is it that we can dedicate resources and support for providers in order to address the needs of their patients in a culturally and linguistically appropriate way. So again, we're hoping to see this bill introduced in Congress in the next month or so. We know that there's other pieces of legislation that we'll talk about later on in the program, but these are all important factors for our community.
Dr. Patel?
Yeah, so Patch, or the Partnership of Advanced Cardiovascular Health, has done really many different things at different levels. I'll start with high level. We've gone to Capitol Hill. We've written white papers. We've increased awareness on YouTube and other platforms as such. And then also, more importantly, we have done things with patients. We did last year the Patches Cardiometabolic Academy, where we actually had patients of different ethnicities talk about their different disease states and be able to do it in an effective manner. These people had a 3-day training. So, for example, we would find a Asian American who had heart disease, and that patient may be very good or have a good understanding of what's going on, but they may not know exactly all the nuances of the Inflammation Reduction Act or healthcare barrier issues. And so we would actually train them with a very well-experienced professional newscaster. Then we'd give them a video of what they did before and after training. We would take them to Capitol Hill to voice our concerns. And the fact of the matter is, the most powerful voice in the room is the patient. So I think that really highlighted the fact that patients have the most powerful voice, and also they give us the most powerful message. And we clearly saw that last year when we took some of these patients to Capitol Hill, to other platforms such as local societies, even churches, even to local community barbershops, places where people met, and these people were able to really relay the message and the concerns they had in a very effective way. And it was very, very reassuring, because after they had done their interviews, you could see the big difference in their confidence, how to convey their message and so forth. So we were very proud of that Leadership Academy, and we are doing it again in May, again for about 20 different patients with 20 different disease states. So keep tuned.
Fantastic. So a question for all of you, really, is what can policymakers do to address barriers to cardiovascular disease care for AA and NHPI patients? I know Adam talked a little bit about HIA, but I will throw it over to Meha.
Yeah, thank you, Madeline. And yes, there are significant reforms underway with policymakers, as we just heard from Adam. There's another one I wanted to bring to your attention related to step therapy. So we've heard already that step therapy is a primary barrier to access to care for Asian American patients. And there's a bill that's been introduced, HR 2630, the Safe Step Act of 2023. And what this act does is essentially ask for reasonable limits on step therapy. Ask the health plans to provide some sort of exemption process so that patients can get the medicines that they need for safe and effective treatment.
Dr. Patel or Adam, do you have anything else to add to those remarks?
No, I just piggyback what Meha said. As healthcare professionals, we really need some reforms on some of these policy-making decisions. I think the step therapy has gone a bit too far, and it's really become a burden to healthcare and also a burden to the patient. So, as has been mentioned, we're very excited to see how far we can get with the Safe Step Act.
Yeah, and I'll just add, I think we really do need to prioritize the communication between a doctor and a patient. And when a doctor does, provide for what the best treatment option is, having these artificial barriers imposed on the ability of patients to access the treatment options, the medications that they need for a non-medical reason, I think really does provide a barrier for our communities. And again, when we're talking about Asian, Native Hawaiian, and Pacific Islander communities, this can be extremely confusing, particularly for patients who may have limited English proficiency or may not have experience with the U.S. healthcare system. Having these, again, artificial barriers being imposed when a doctor is really laid out what the best treatment course and the treatment option is for a reason that is not medical, I think is significant. It poses significant challenges. So really think that we do need to rein in this practice, and we are very excited to be a supporter of the Safe Step Act as well.
And to your point, Adam, we all need to reach out to our members of Congress to further convey the Safe Step Act, as well as all our different coalitions that we represent, to join the Safe Step Act coalition, so that we all together as one will be a much bigger ship.
Meha, despite cardiovascular disease's high prevalence in the United States, including in AA and NHPI communities, new cardiovascular disease drug development has started to shrink compared to other therapeutic areas. What do you think needs to be done to improve cardiovascular disease drug development?
Yeah, thanks, Madeline. The Inflation Reduction Act undermines cardiovascular drug development, as well as research and development in a number of other therapeutic areas. Specifically, things can be done to mitigate this risk. We must protect research in areas, in addition to cardiovascular innovation, in areas such as orphan drug development, biosimilars, as well as small molecules. And actually, a bipartisan legislation has been introduced, HR 5539, the Orphan Cures Act. And this would allow orphan drugs to add additional orphan indications without being penalized. So thinking about what to do to really bring back innovation, mitigation steps must be put in place to mitigate the effects of the Inflation Reduction Act.
So a question for all of our panelists. What other policy or practical solutions would you implement to galvanize action around cardiovascular disease care for AA and NHPI patients and half the number of cardiovascular events by 2030? Dr. Patel, I'll start with you.
Yeah, I think one thing that we talked about earlier was prior authorization. We definitely need some practical, pragmatic, common sense approach to prior authorization. I think it's gone a bit too far. I think the AMA and other big societies have also recognized this. We need to have a way, regardless of socioeconomic status, race, ethnicity, we need to cross those barriers of culture and be linguistically feasible for all. So I do think there needs to be some reform in authorization that really has become a big obstacle. I think it needs to become easier.
Adam?
Yeah, I think it really is centering community and patient voices and the communication between doctors and patients, and ensuring that Asian Americans, Native Hawaiians, and Pacific Islanders, one, have the information that they need in a in language and in a way that they can understand their risk factors, both genetic and otherwise, so that they can be aware that they may have a predisposition to cardiovascular disease as well as other diseases. Two, I think that, we mentioned some legislation during this webinar, HIA, the Safe Step Act, and reining in some of those other practices. And I think really we need to, members of Congress need to hear from community members, from other organizations, that this is a priority for the Asian American, Native Hawaiian, and Pacific Islander communities because they do provide artificial barriers in order for patients to get the care that they need. And three, I really do hope that I want to underscore the need for better data on our communities because while we have some information on the impact of cardiovascular disease for some members and some populations within our communities, for a vast number of the more than 50 ethnicities that comprise the Asian American, Native Hawaiian, and Pacific Islander big umbrella, that information is just not there. And again, it makes communities invisible. It makes it so that we cannot target interventions where they are needed most. And that leads to worse health outcomes. And with better data, we really do hope that we can address this issue, as well as the host of other health disparity challenges that our communities are experiencing.
And Mayha?
Right.
Yeah, I think all of you listening to this call are all here because you want to take action. So you've heard a number of ways to take action. I think the one more piece for me to emphasize is reach out to your member of Congress and encourage them to co-sponsor the Safe Step Act and pass it into law.
I do want to piggyback on what May has said earlier about the Inflation Reduction Act. Dear to my heart, of course, is cardiovascular disease. And we know that, for example, when you do large cardiovascular enrollments, on average, there's a 67% greater enrollment than other cardiac or non-cardiac type studies. We also know that there's about 28 to 32% longer duration to complete these studies compared to metabolic and respiratory disease trials. Now, on top of all that, they generally take about 40% more trial sites, and also they have a lower success rate compared to respiratory disease and other metabolic diseases. And why do I think this is all important? Because the fact of the matter is, at least as we talk about the Inflation Reduction Act today, 5 of the 10 medicines on the Inflation Reduction Act are cardiovascular. And the other point I want to make is that most cardiovascular drugs on the market are very high risk for IRA negotiations. In fact, most cardiovascular drugs are small molecules. And what does that mean? It means that these are therapies which are thought to be different to biologic type medicines. And why is that important? Because biologic type medicines generally have 4 years later in negotiations, but the small molecules now will be up for negotiations 4 years earlier. And why do I think that's important? I can give you a great example of a compound or a group of medicines called SGLT2 inhibitors. If, for example, they had gone through the Inflation Reduction Act today, we would not have all the different indications that they have now, including, for example, SGLT2 inhibitors not only are, quote, sugar-lowering therapies, they help heart failure, they protect the kidneys, they reduce cardiovascular events. If that therapy today had been under the Inflation Reduction Act, industry would not been able to sustain or open up different indications for this product. So this is very near and dear to my heart because I think the Inflation Reduction Act will really limit our ability to expand indications of compounds because the timer starts from the moment that they are put on the market.
Well, thank you to all of our speakers. Unfortunately, we have to wrap up. And I want to also mention that September is Cholesterol Awareness Month. It's been designated as Cholesterol Awareness Month. So this designation highlights the urgent need for screening and treating of LDL to reduce the risk of cardiovascular disease and heart attacks or strokes. And I hope you've learned as much as I have from our amazing panelists as we commemorate National Minority Health Month. We greatly appreciate our briefing partner Amgen, as well as all of our special guest speakers. And your support enables APAICS to fulfill its mission of promoting Asian American, Native Hawaiian, and Pacific Islander participation and representation at all levels of the political process, from community service to elected office. So please visit www.apaics.org to learn more about our work and to view previous events. Thank you for everyone for tuning in, and have a great rest of your day.